Okay, welcome everyone. Once again, we are here for a series of lectures that will be sponsored and provided by the East Texas Geriatric Education Center Consortium in partnership, as always, invaluably with the Texas AHEC East group. Just to give you an idea, this is today's agenda. There are lots of handouts, lots of information. I just want to spend 5 minutes going through some things that we need to go through, not only to introduce the speakers, but also to go through our continuing education instructions and what is required for that. But this is more or less what's going to happen. We'll have a couple of presentations, a short break, one more presentation, and then at the end have some time to fill out some evaluations. This series has 4 different sessions focusing on addressing difficult topics in aging and disease. I'd like to acknowledge the use of the input of our program planning committee to help put this together. It's been a great adventure trying to figure out the types of things that we want to try and do. February, we'll be looking at mental health disorders, mostly dementia and depression. In April, we'll be looking at cancer issues, screening, treatment, post-surgery, surveillance, and symptom end-of-life issues. And in May, modeling for long-term care, focusing on older prisoners and nursing home residents. These are learning objectives. They are listed, again, in your handouts. We have 8 of them, and it's going to cover quite a bit of material as an overview of aging and disease. We teleconference to 5 sites throughout East Texas as part of our consortium for the ETGEC, Lamar University in Beaumont, Stephen F. Austin in Nacogdoches, Baylor, over in Waco, Victoria College in Victoria, and Weatherford College in Decatur. And we'll be bringing them on the screen. You'll see them when we have some discussion. We have ways of doing that. For CE, we offer CME credits, and all the paperwork is in the back there. Please make sure that you sign in. This is good for 3 hours. And there is an evaluation form, attendance record that you'll need to fill out, and then we'll mail you and send you a CME certificate if you're eligible for that. We also have CEUs for social workers. There's a sign-in sheet that you just need to take care of, fill out, and submit a registration form and a general evaluation form. For nursing, we have 3 hours nursing credits for RNs and LVNs. Again, there's a sign-in sheet. There's a form to fill out for your submission, and then we will be able to provide you with a certificate as you leave. So we have certificates already printed out. We'll put your name in, and you'll be done. Then you won't have to submit anything else. Okay? We have CEUs for physical therapists and occupational therapists. That's simply just filling out one of the evaluation forms. Let us know what you would like to receive, and that'll be also on the sign-in sheet. All right? Okay, any questions regarding what's required for the CE? All right, good.
I'm going to take over this talk from the theme that Dr. Goodwin's laid down, which is, we can really do a lot of harm to people by following rules that were established in the younger population and applying it willy-nilly to people in their 80s and 90s. But I'm going to focus more on a segment of that population, which is a population living with advanced dementia. This population is unique because, as you all know, just like hypertension, there is a proportional rise in both the incidence and prevalence of dementia with aging. In fact, by the time you get to 85 and above, some studies estimate the prevalence of dementia to be as high as 45%. So this is a population where we can really do a lot of good if we use wisdom, and we can really do a lot of harm if we just use fixed rules that were not meant for these people. And this is going to be the theme throughout these 30 slides that you're going to be watching. Now, at this point, since I'm talking about advanced dementia, and we all come from different areas, so by the time I finish, we're all going to know the reasons for this overtreatment, and we're going to discuss some of the quality of life implications of certain interventions and screening in this population, hemodialysis, tube feeding, cancer screening, and we would then look at strategies to improve care in these people. Quality of life, that is the theme. Now, in order to really put this in context, I would like you to watch this video with me, and I hope this is by Angelo Volandes from Harvard, published a study using this video to educate people.
Has advanced dementia.
Okay, good.
An incurable disease of the brain. She cannot talk or communicate understandably with others, as we see here with her daughters.
Did you go to girls' high? I do. So tell us now, how many daughters do you have? Huh? How many of us? One?
I don't know.
Two? You don't know? How about four? Did you have four girls? Libby.
No. Just leave it alone.
People with advanced dementia cannot walk or sit by themselves. They cannot feed themselves, and many times develop problems with chewing and swallowing.
That's okay.
Let's wake up our taste buds first, okay? Wake up our taste buds first. Chew, mama. That's a girl. Chew good. Yeah, chew. Chew it. There you go. Keep going. Now, one time. Almost no prompts were needed. Hi, Mama. There we go, sweetheart. Yeah, you can do it.
Advanced dementia is an incurable disease and most commonly occurs after many years of Alzheimer's disease or a number of strokes. People are not able to answer any questions or tell you about themselves.
Okay. What do you think the percentage of patients like this? This is what they call stage 7. That is a classification of dementia or based on functional decline. And this is a patient that will be what they call the stage 7 or advanced dementia. What percentage of patients like this gets screen mammography? No, in real life. Meaning if you go to the community now and do, take a patient like this and look for the past 1 year and come up with a very simple prevalence.
10%.
Yeah, 60%, yes, screening from 18% of these 18% of patients that I just showed you get screening mammogram. Now, that percentage varies. If you have a net income of $100,000 or more, net income or net worth, I should say, the prevalence goes to 45%. Which means if you divide the people into, you know what I mean, to the well-to-do versus the less privileged, the prevalence goes up to 45%. So everything I'm going to tell you in this talk, I want you to always think of this woman. This is a real patient. It's not an actor. In fact, the family and Angelo Volandes, who published using this to educate people, use this to show people when they go to certain nursing home. So, okay, great. So this patient basically shows evidence of inability to recognize family members, cannot say a lot of, very few words. She's dependent on all activity of daily living. And as you can see there is a lot of what they call pocketing of food, which is food in the cheek. She definitely requires help with fecal and urinary continence. And if a lot of patients like this, most of them live in nursing home, and 70% of them will die in nursing home. Now, there is no cure for the condition I just showed you. So our job as healthcare providers, in whatever discipline and specialty, is to avoid doing harm and focus on maintaining quality of life within the context of the disability. But we do spend a lot of money doing things that may not be necessary. In fact, in 2001, almost $183 billion were spent in this kind of disease. This is not about cost control. It's about doing things to improve quality of life and avoiding interventions that may harm the patient. This is a study that was done by Dr. Mitchell, published in England Journal of Medicine. What they basically did is to get about 300 of these kind of patients living in nursing home, and they followed them. This is an observational study. They didn't do anything. They just followed them for 1.5 years. And within that period, as you can see, 55% of them died. It's not surprising there's a lot of aspiration pneumonia. You can almost see it coming on. A lot of infectious disease, mostly in the skin and in the bladder. And almost all of them develop some kind of eating problem, dysphagia. So this is the kind of patient that you want to be careful thinking about what you do, both for diagnostics as well as intervention. Now, the implications of screening mammograms in patients with advanced dementia are many. And I want your opinion of what you think is going to be the next course of action if you screen that kind of patient for mammogram. Let's say you find a malignancy. What's the implication of screening mammogram in patients with advanced dementia? Any comment?
Probably get a biopsy then and then surgery, or at least treatment with chemotherapy.
It's putting them through something they can't understand and give consent.
That's very important. How about rest of mind? I just want to have a rest of mind to, so that I can know that at least it's not there. Which is some argument people sometimes use. We just want to know. She is not aware of the concept of rest of mind. So, and to me, one implication that is really important to me a lot is, how do you communicate side effects of treatments? And that is one thing we all have to keep in mind when we have interventions in patients with advanced dementia. The implication of course, adherence to treatment, but more important, and we see this a lot of time, and we're going to go through some cases on applying guideline recommendation to elderly people with advanced dementia who may not be able to communicate the earliest side effect symptoms to you. Of course, Dr. Goodwin really discussed about it. Before you get the mortality benefit from mammogram, you at least need to live for at least 5 to 7 years. From the study I just showed you, almost 50% of patients with advanced dementia, I'll show you, they die within 18 months. So it is important to always sit back and say, am I doing more harm than good? And the first duty of any clinician is do no harm. So let's, so because of this, the outgoing director of Center for Medicare and Medicaid Services was interviewed before his recess appointment ended. And apparently that time he could speak more openly. And what he said was that almost 20 to 30% of healthcare spending is waste. And a lot of the waste is from overtreatment and overdiagnosis. So as we go through this talk, we're going to look at some of the contributors to this overdiagnosis, including failure to coordinate care. I've done the MRI here. We're going to repeat it again somewhere else. Then the administrative complexity of the healthcare system. Rules that actually encourage us to overtreat. Potential fraudulent practices. Think about it. The prevalence of screening mammogram in people with net worth of $100,000 with advanced dementia is about 45%. So you wonder what is driving that kind of data. So if you're going to save Medicare, but more important to this story, if you're going to improve quality of care in people with what you might call end-of-life conditions, we need to start thinking in a very broad manner. So this is, ordinarily, JAMA doesn't publish case reports, especially a case report of things that are well known. But this is a case report that was published in 2000 in JAMA of an 85-year-old woman with a history of Alzheimer's dementia and with osteoporosis. She came to the clinic with back pain, X-ray show osteoporotic fracture. Patient was given some pain medicine, as well as Alendronate, which is a medication to prevent fracture in the future. And she lived with her family. They went back home. The instructions were as listed on this. You wake up the first thing in the morning, take it on empty stomach with a cup of water, stay upright, do not eat or drink anything for 30 minutes thereafter. What do you think happened to this patient? And will you do anything different if you are the clinician, whether you're a nurse practitioner or a physician assistant or MD taking care of this patient? Anything you do differently within the context?
As far as quality of life, it's the Alendronate that requires the special care afterwards. And might think hard about, is this something that's really going to benefit the patient?
That's very important. You weigh the burden. You know, is she going to live enough to derive the advantage of preventing osteoporotic fracture the next one? What's the implication of this medicine here? Exactly. If they give it to me and I develop severe erosion, I would know right away. I will start having pain. Of course, I will stop it. Then I'm going to call my doctor, and maybe I will prevent it from happening. She is unlikely to tell us that I'm having some heartburn. She might have some degree of agitated delirium, but, you know, anyway, this is an unusual thing for JAMA to publish a case report, but this is just to make a point that when we apply guideline recommendation, we have to look at the context. And as you can see here, 4 weeks after starting Alendronate, she went to the local emergency room with complaints of acute onset of shortness of breath. Evaluation showed an esophageal rupture, secondary to ulceration. There was no mass. Despite chest tube drainage and operative intervention, she died when the ulcer eroded into major vessel. Somebody could have argued, maybe she should be on IV once a year as Alendronate acid. You monitor her right there. But the point is she going to even live long enough to derive the advantage? But the point is, you know, applying the rule to a patient with advanced dementia, we always have to think of all the implications of it in terms of do no harm. This is a case discussion that's we're all supposed to participate in. A 74-year-old woman with advanced dementia requiring 24-hour supervision. She has never been screened for cancer. She lives with her daughter, who wants to know which health screening will be appropriate. Which of the following should you recommend to this 76-year-old woman? Colonoscopy. Remember the patient I showed you before. Just always put that at the back of your mind. And I deliberately showed that so that we can put it in context. This is not about rationing. This is about doing the best for our patients. Any taker for colonoscopy? Mammography. Fecal occult blood testing. Pap smear. No testing. It's amazing when it comes to pap smear. Women, about 20% of women who have undergone hysterectomy, they get pap smear. Anyway, you're right. The answer is no testing. But you know what? In real life, a few research actually went out to really know what is the real life findings when it comes to this screening. And you'll be surprised what they found. I've already mentioned the 18%, 47%. What you find here is that the caregivers of patients with advanced dementia, they have the wisdom to know that I don't want them to go through the trauma of going through the mammogram, but in most of the cases, it is the doctor or the other clinician who are trying to convince them. And you know what? A lot of patients listen to their physician or their clinicians and say, hey, look, you know, my doctor said, look, she's going to get breast cancer and then it's going to go all over. So it's actually the physician. And if you are married, or if you are like people here making over net worth more than $100,000 a year, then your chances of getting mammogram is even 47%. This is a real eye-opener because not only is there no benefit, but as Dr. Goodwin alluded to, you will get false positive tests. All these calcified nodules that will require more compression, ultrasound, and more biopsy. And in this situation, you are likely to detect clinically insignificant malignancy that will cause no problem in patient lifetime. And yet, they are more likely to undergo all the things you mentioned, biopsy, chemotherapy, and so on and so forth. But more important to us here as geriatricians, as a geriatric MP or geriatric PT or physician assistant is that focusing too much on all these take time away from what we should really be doing in terms of attention to nutrition, attention to caregiver stress, prevention of fall, prevention of constipation, decubitus ulcer, because we are focusing on things that not only does not benefit the patient, but is likely to do more harm to the patient. So this is another case, 83-year-old nursing home resident, Mr. DJ, with advanced Alzheimer, has been losing weight, 11% of his weight over 11 months. His current weight is about 146 pounds, BMI of 22. He has not had any hospitalizations, acute infections, or other serious medical problems in the last 1 or 2 years. Since his nursing home admission, he has had a slow, steady decline in cognitive function. He's on metformin for diabetes. His diabetes is well controlled, hemoglobin A1C of 6.2. He's on atorvastatin, which is Lipitor, 40 milligram daily. He's on medicine for dementia called Namenda. At the beginning, the patient was doing well, fully ambulatory, and attend most meals in the resident hall. He needs minimal feeding assistance. He's on low cholesterol and diabetic diets, modified to include finger foods. According to chart documentation, he only really consumes less than 75% of the food served. But when you do a 2-day calorie count, you realize the patient actually is taking about 40% of the food being served. The low cholesterol and ADA recommended diabetic diet for this patient. So, dementia patient with weight loss. So the question now is, besides comprehensive evaluation for potentially reversible causes of the weight loss, which of the following is least likely to help these patients with dementia, and weight loss, and well-controlled diabetes, and hyperlipidemia? Audience participation from...
What's the definition of help?
Well, help in this patient is about reversing the weight loss.
Reversing weight loss.
Yes, because that is why they call the nursing home doctor that, look, we don't want to be cited for weight loss, Least likely.
Least likely?
Yes. Yes, because why do we need to stop the metformin? Yes, GI side effect. Metformin can also promote weight loss.
She's having a low caloric intake.
Yes, low caloric intake. The diabetes is too well controlled for our age. The goal set by the American Geriatric Society is between 7 and 8 for the hemoglobin A1C. Change the diet from diabetic to regular diet. A program of individualized feeding program. Why should we stop Lipitor?
She's losing weight.
She's losing weight, she's not even eating enough. The last thing you want to do is to further promote the weight loss. Now, the problem with PEG tube is really very complex. And you might argue that this patient is losing weight. Why don't we put in a PEG tube? But studies upon studies that are published on PEG tube in the context of advanced dementia, they've not been shown to improve survival. And they might argue that, well, in that patient we just saw in the video, maybe you put a PEG tube, all this food being fed is not going to go into the wrong pipe. In fact, studies have shown that you actually increase more of the aspiration because you now have more food in the stomach that will go up and then go into the lung. It does not heal or prevent decubitus ulcers in the context of advanced dementia. And it actually worsens functional status because of all the issues related to the PEG tube. And yet, 1/3 of nursing home patients with dementia, advanced dementia, have a feeding tube inside it. Somebody might actually argue, maybe it's improving the quality of life of that patient, so the patient doesn't die from starvation. Anyway, in fact, most patients get this feeding tube when they go to the hospital for something else, usually pneumonia, which as you can see is very common with all the feeding problems, or dehydration, or for dysphagia, which is part of end-stage dementia. In fact, when people do qualitative studies, which people don't want to do, but is as important as quantitative number studies, they ask people at the early dementia and their family, what would you like when you are presented with this state? Like being shown this video. This is what Angelo Volandes does most of the time, to ask people, if you're in this state, shown in the video, will you like this? Will you like that? And most nursing home residents will rather die than live in a state of advanced dementia with a feeding tube. This is a qualitative study, asking people their opinions about different topics. Now, the question is, what happens after you get a feeding tube? Maybe things get better. What happens is, even though it's not improving your functionality, what can happen is 64% of patients who got a feeding tube, advanced dementia, they die within 12 months. And within those 12 months, in fact, within 4 months, 20% of them will have to go back to the hospital for something related to the feeding tube. It's clogged or it came out. And in fact, when people look at hospitalization after the feeding tube, dementia patients with PEG tubes spend 9 days in the hospital for issues related to feeding tubes. And every time you transport those patients from the nursing home to the hospital, they experience considerable trauma associated with hospitalizations. So this patient came back. This patient, you saw the patient in the nursing home, you do the right thing. You stop the Lipitor, you stop the metformin, you tell the patient to eat whatever, to eat the typical American diet, everything. The weight increased to 160 pounds. But 6 months later, the patient developed sudden onset of shortness of breath with left-sided chest pain and cough productive of bloody sputum. Patient was taken to the hospital, to the emergency department. They did all the usual blood testing and had a CT of the chest that confirmed pulmonary embolism. So patient received the appropriate treatment with heparin that was later changed to Coumadin. The test, which is the CT angiogram, you use a lot of dye, and some patients, when they are dehydrated, sometimes develop what they call contrast-induced nephropathy, which means contrast-induced kidney failure, was seen by the renal team. After the creatinine stabilized, the patient was discharged back to the skilled nursing facility with a good INR of 2.2. Labs were repeated, potassium was 5.5. The kidney function improved a little bit from 6 to 4.8 to a new baseline of GFR less than 10. Patient now has become much more functionally declined, able to walk only a few steps, and is dependent now on all ADLs except feeding. So patient saw outpatient nephrologist. I don't think I've seen a nephrology in nursing home. And the nephrology recommend to initiate dialysis in order to control all the various issues related to declining kidney function. So his daughter now talked to you when the patient is back to the nursing home in the skilled nursing units of the nursing home and wants to know from you as the clinician whether initiation of dialysis will be appropriate because the nephrology is calling that they want to put in the access line next week. So what's your opinion? How will you advise the daughter with respect to these patients who has what you might call end-stage renal disease right now? What advice are you going to give to these patients? No dialysis. Well, when you think about it from the quality of life, it's all about quality of life. Now, this is not about rationing. This is about telling patients information so they can make rational decisions that will be good for their loved ones in the context of dementia. What this patient, Kurela did and his colleagues is to basically again do observational study, published in England Journal of Medicine. They follow 370 patients with end-stage renal disease. And then out of those patients, only about 22% had advanced dementia. So it's not only patients with dementia, there are other patients with all the usual problem. And then what they did is they followed them and to see what actually happened. Most of these patients started their dialysis initiation when they were hospitalized. In fact, this patient will have started it while in the hospital for the PE. So what then happened is they follow them for the next 12 months, so trying to see what's exactly happened to them. Maybe they have better quality of life. What they find is 87% of these patients were either dead or they are more disabled than before they started dialysis. And only 13% of them actually maintain their pre-dialysis functional status. In fact, the probability of being dead or having worse functional status, is predicted by either history of stroke or dementia or being hospitalized during the initiation of dialysis. Of course, also by evidence of malnutrition. A huge decrease in average functional status 3 months before and 1 month after the initiation of dialysis was observed. What we find here, as you can see here in this slide, is 3 months, this is months on the y-axis, and this is the percentage. Within 3 months, this is of dialysis, about 25% or 20% died. And by the time you get to the 12 months, close to 75 or 78% of the patient died. And by the time you get to 12 months, all you have is only about 13% able to maintain their function, and about 90% are completely disabled. So this is the kind of information you want to present. This is not about telling them what to do, but you need to let them know so they can make an informed decision that this is what may happen. It's not going to necessarily prolong their life, but if anything, the patient might have a worsening of their functionality and their quality of life. In fact, some of the nephrologists are already looking at this to the extent that this person wrote an editorial talking about maybe it's time we should stop dialyzing the dead and treating other patients too aggressively. Again, this is not about rationing. This is about, are we doing more harms or are we doing more good? Which in this context of advanced dementia, especially people who are disabled living in nursing home, we may be making their quality of life worse without necessarily adding any quality of life. So the question is, why would we be doing dialysis, PEG tube, colonoscopy, and mammogram in the patient you watch in the video? There are many reasons, but one of the major reasons is many of these patients, if you don't have directives to your healthcare providers about what you want, if you should develop, in fact, the video is used for education. If you are like this, what will you want, what you don't want? There is, not a high percentage of people have advanced planning directives, and that could contribute. So you leave the family and the caregivers in a dilemma, and people want to avoid blame, potential lawsuit, and so on and so forth. The other one is, it's very difficult to predict 6-month survival in advanced dementia sometimes. I've had patients living the way in that video that have been around for the past 1.5 to 2 years. It's amazing. So it's not always easy. And people are coming up with a lot of risk algorithm based on observational studies. That's what's good about this observational study. You study thousands of people and you use the information to predict probability of living to 6 months to 12 months. And then other thing is we clinicians telling patients that, if you do this mammogram, we might give you some rest of mind. Telling the family of the caregivers, there may be other reasons why we are misinforming the patient's proxies. There are cultural influences. Several studies have shown that African Americans and Latinos are more likely to get PEG tube and a lot of these over diagnostics. Now, those are studies that are just observing what they find. Then they will try to look for potential reasons, but that is what is, a lot of it is also due to the fact that many people might have not had good access to health care before they became 65. And now when they go to 65 and they go to Medicare, and if the loved ones should have advanced dementia, they say, well, it's the time now that I just got on it, and that's when you want to tell me I'm not going to put him on dialysis. So there are a lot of complexity in terms of the cultural influences. The other one is not every community has good access to a palliative care and hospice program. But more important to this talk, but people don't talk about it, is that there are incentives in the Medicare program to put everybody on dialysis, to put PEG tube in everybody, to screen every dementia patient, even people on hospice, to screen them. And some of the incentives are, if I will just mention a few. Think of yourself as the owner of a nursing home. You own a nursing home, you are the director of the nursing home, this is yours, you bought the building. And you have all these Medicaid patients there. And they are paying you about $100 per day, per person for long-term care. If that patient, just think of that patient, if a patient there develop, a bladder infection, that, you can start the first treatment with an antibiotic like levofloxacin, IV, for the first day, and dehydration. So you can actually do this in nursing home, a little bit of fluids in the IV line, plus Livaquin, and the following day you put the antibiotics in the mouth and patient get better. You are actually indirectly penalized for this because all this is going to come out from your $100 per day. So, however, if you send that patient to the hospital, first of all, you're still going to get your money from Medicaid. There's something called bed holding policy. So if you have 20 patients in your nursing home and all of them are in the hospital, you're going to get 10, your daily payment. Plus, when those patients come back, after 3 or more nights of admission to the hospital, now the money making starts. They now go back to what they call the skilled nursing facility, which is the same bed, but now you get reimbursements at 3 to 4 times the daily rate. So these are insane. Now, I'm not saying they're doing it for that reason, but it's definitely, people don't want to lose money. So these are kind of incentives. I should call it incentive to send patients to the hospital. Maybe with the new healthcare system, with the so-called bundling, whereby they just give you one money for if you are in the account care organization. But that is one of the reasons that there is a lot of overtreatment. And sending patients to the hospital is not benign. There are a lot of things you can all imagine. Infections, bed sore, falls and fractures, delirium, exposure to medical errors, complication from procedures, and then a risk of readmission, stress to patient, to the family, loss of property, including dentures and glasses and hearing aids. And then the fact that you are sent to the hospital, the fact that that patient with a bladder infection is sent to the hospital, you've already created a new syndrome. No matter what you want to call it, syndrome sent to the hospital. Because now, you are now at risk of all these pacemakers, dialysis, feeding tube, plus all this. So the very act of being sent to the hospital creates a whole new syndrome that, you have to then treat in addition to the same medicine they're going to give in the ER and so on and so forth. In fact, when in a study that actually look at people, this is a retrospective study, they look at people who are already dead, and they're going back to their charts and look at what happened to them in the last months of their life, 12 months before death. And 1 in 5 nursing home patients with advanced dementia, they actually transfer to the hospital or a new facility within the last month of their life. Indeed, some of them actually end up getting their feeding tube 3 months before they die. Some were admitted to the ICU 30 days before death, and stage 4 ulcer was present in some of them. So this is obviously an example of suboptimal end of life care. Now, you could be asking the question, why can't we do the right in nursing home? Of course, the first one is the incentives to take the patient to the hospital. The other one is sometimes it's just difficult to get the needed therapy and diagnostics. Advanced care planning may not be present. The staff, there's a shortage of staff in the nursing home. There's a very high dementia prevalence. And you may not have access to simple tests. Maybe you want to do a quick chest x-ray or do measure the hemoglobin. And more important also is a lot of illnesses in the nursing home population, especially a patient with dementia, can present in a typical manner. And then there is the concern about legal and regulatory concerns. A lot of physicians and other clinicians don't talk about it, but the fear of lawsuit sometimes drives over treatment and over diagnosis. And people now engage in defensive practices, which might now erode patient autonomy and patient quality of care. Now, this is from the same slide of the case report in JAMA. And the reason why I want to show this slide is to all of us to always stand back and think that whenever we have a patient with cognitive impairment, from the mildest to the most severe, we should always consider the alter risk-benefit ratio, balancing safety and autonomy within the context of these challenges: decreased decision-making, the increased caregiver burden, risk of diagnostic procedures, adherence problems, difficulty reporting side effects, and difficulty titrating medicine based on reporting by patient. For instance, you don't want to do a PRN pain control in patient with Alzheimer's disease, simply because as needed medication requires some degree of coordination. And we also have to look at the decreased life expectancy. As Dr. Goodwin said, that the rules of medicine derived from younger people with no dementia do not always work well, particularly not only in the variable, but in the context of patients with advanced dementia. So we have to always keep in mind the life expectancy, whether patients have sufficient life expectancy to realize benefit from this mammogram, like the patient we show. But obviously, there are still a lot of things we don't know. We don't know how to predict very well the survivor. So we need policy changes as well as inclusion of patients with dementia in a lot of studies. Now, I think the key to preventing some of this overtreatment and overdiagnosis is better counseling of the families and proxy of patients with advanced dementia. In fact, what Dr. Yolandes, who allowed me to use this video, have been doing a lot of nursing homes, is they did a study whereby they have a control group. They showed the video to them, and to the case group and the control group, and they were able to see a difference in adoption of advanced care planning and a difference in use of invasive diagnostics and therapy based on this. The control group just get verbal instructions that when people have advanced dementia, this is what happened, and so on and so forth. Other thing that have been shown to decrease overtreatment in dementia is having a special care dementia unit, because they are focused on all this. But very important is to realize that when a patient is in stage 7 of dementia, like the patient in the video or the DVD, that's actually a very good indication to consult Dr. Grumble, who's right here. That is when you want to do palliative and hospice care. You don't want to do dialysis. That's not the time to start screening for colon cancer. So it's about doing no harm. It's about improving the quality of life of patients. It's about avoiding harmful procedures. So, of course, advanced directives is very critical. And people have looked at some of the studies that look at it. In fact, in a study that was published last year in JAMA, we had a look at, nursing home patients who were hospitalized. Only very, very few of hospitalized nursing home residents with advanced cognitive impairment had an order to stop artificial hydration and nutrition. So the solution is about education. Well, when I say education, it's about telling them the data. It's not about telling people, and I always tell my fellows and students and residents, it's not about telling people that this is a bad decision or a good decision. It's about telling them if you choose plan B or plan A, these are the expectation the next 12 months. Because we do know from study of 300 people or 500 people that when you do dialysis, when you do chemotherapy in the concept of advanced dementia, this is what you should expect. And if you are ready, or if the patient could tell you they want to live with that, it's important to take that in consideration. So advanced directive about do not resuscitate others, discussion about artificial hydration, and discussion about hospitalization when patient is terminally sick. This is a study that I like to show a lot. This is a very interesting study from two, one of them is in Journal of Advanced Nursing, the other one is BMC. What they basically, again, this is almost observational studies, looking at the implication of having nurse practitioners working in long-term care homes. And these are very busy MPs because, as you can see, they cover 22 long-term care, serving about 2,000 residents. So one of them is a Canadian study. Anyway, and what they could see is that they were able to prevent hospital admission for potentially treatable condition, about 40% of the patient. This is not about cost saving per se, it's about those patients not being subjected to the hazard of hospitalization, losing their dentures, getting all the bed sore, exposure to hospital-acquired infections. And then what they also noticed is that the staff of the nursing home, all the way from the director of nursing to director of administrator to the CNA, there's increase in the confidence and job satisfaction. As a matter of fact, they were able to teach all these people a lot of new skills, in terms of working with patient in nursing home. Of course, they also look at cost. It was cost neutral, and there was no increase in cost. But you cannot really put cost on the quality of care increase that you get for not admitting all these patients to the hospital in terms of quality of care. So it is important to recognize that patients with advanced dementia, they have limited life expectancy. The median life expectancy for advanced dementia is about 3 years. And when you are thinking of diagnostics, you are thinking of therapeutics, you always have to keep that in mind. And you have to tell the families of patients about some of the implications of medical interventions like dialysis, PEG tube insertion, ICU transfer, as well as some of the cancer diagnostics. I want to thank all of you for being here, and I'll be more than happy to take your questions and comments. Thank you.
There's several minutes left.
They use a most form, which allows the patient and the physician together to sort of specify some of the things that you mentioned regarding rehospitalization, use of antibiotics, use of IV fluids, those sorts of things. It's quite a bit more specific than our typical advanced care planning or living wills or what have you that we might use here. Are you aware of any such document or any attempts to develop a document for the state of Texas?
Well, there is Texas directive to physicians and clinicians that In fact, it's a requirement, is a part of the law in Texas that everybody coming to the hospital, you get this information about, your rights and your advance directives. Now, it's not, even though the paper and the directive is there, but without what I would call a systematic program to actually take that as an important aspect of care, not only in the hospital but in nursing home, just giving the paper to the families is not going to cut it. It's about actually having, in fact, this video, they've used it a lot to say, look, will you, particularly people who don't even have dementia, that if this happened to you, will you what do you think about all these interventions? So I think the North Carolina documentation is definitely in the right way. The process of getting the advance directive from our patient and their family is as important as all the other things we do for them, because one can potentially prevent some of the hazards that are outlined in these particular slides.